Okay, good evening, everyone. I'm really happy to see you all after this long vacation, this long time. Tonight we'll be having our second part of the talk we had last week regarding guidelines and recommendations for resuming elective plastic surgery services in times of COVID-19 infection. Last week, or maybe 2 weeks ago, we had a talk regarding the USA perspective and how they dealt with their elective activities and services during the COVID-19 infection. Tonight, we'll be having Dr. Haitham giving us his experience and the NHS perspective towards the COVID-19, how come they manage their elective cases in such a time. But first of all, I'd like to present my professors and our panelists for tonight. Professor Dr. Tariq Mahboub, Professor of Plastic Surgery, Cairo University. Professor Dr. Hisham Al-Saifi, board certified plastic surgeon and associate clinical professor of plastic surgery, University of California, Los Angeles. And of course, Professor Dr. Ma'moon Ismail, emeritus professor of plastic surgery, Cairo University, and head of scientific council of Egyptian fellowship of plastic surgery and Arab board of plastic surgery. Now we'll be moving to our main speaker of tonight, Dr. Haitham Khalil, consultant oncoplastic and reconstructive surgery, honorary senior clinical lecturer, plastic and reconstructive surgery division, University of Hospitals, Birmingham. Pleasure, Dr. Haitham, if you'd like to start.
Yeah. Good evening. Thank you very much for this kind invitation, and Prof. Tariq, Prof. Khalid, Prof. Ma'moon, to share some of this experience regarding how to resume elective surgical care from the UK NHS perspective, and at the same time, just along the same lines, what Hisham and Ahmed has already presented and highlighted kindly in the last session. هو في debate about opening the economy versus health consideration is in this pandemic is quite very evident. فاهم قصدي لما بنقراه في معظم البيبرز أو حتى الجرايد. When I'm sure there will be those who will agree that in order to control the pandemic, you have to impose a lot of restrictions, but on the other hand, it will cause a lot of drastic negative impact on the economy. But on the other hand, there are those who disagree with this, similar to the same concept زي في أمريكا, and it's not actually a true dilemma, it's a false dilemma, when there should not be trade-off between targeting the coronavirus وفي نفس الوقت to restart the economy again. So basically ما فيش magic يعني solution, and it's something that we have to consider when we do the discussion. So there is difference for America, difference for Inglaterra, difference for us. So it's all about looking into the local authorities, and I'll come into this as I go with my presentation. Yeah. So regardless which vision we are taking, هتفرق معانا in terms of إن هي هتبقى down to the country, down to the local authority, and it's even down to the organization أو الانستيتيوت نفسها. وكل institute, كل organization هتبقى looking على pros and cons of starting, not starting accordingly. احنا طبعا احنا دلوقتي احنا في phase 2 في ال NHS response. كان في phase 1, which I will not go through the details of phase 1, but I will mention two factors for phase 1 which has helped us a lot in phase 2. phase 1 في April ال government وال Department of Health حطت ايديها على كل ال private hospitals او private بيسموهم ال independent hospitals هنا عندنا في انجلترا، بحيث ان هم they can provide more capacity to help the NHS, and literally all private hospitals all over the UK were under the control of the government and the Department of Health. الفاكتور الثاني ان الجفرمنت Department of Health والميليتري الMOD حطوا وبنوا 5 مستشفيات بيسموهم النايتنجيل، والcapacity of each one of them is between 3,000 to 4,000 beds. And again, the same aim was to make sure that they provide capacity for this pandemic and to manage this pandemic in the way if the figures get out of control. Yeah. This means that the NHS will be starting to concentrate on starting the usual pathways for the patient as in the pre-COVID area. aim بتاع phase 2 was to resume elective pathways within a safe environment. ودي كانت three factors which are quite very important. The patient will staff safety. We're redesigning the space with capacity in order to achieve very safe pathways للcirculation بتاع ال patients وبتاع الستاف. وكمان reconfiguration and recycling of the staff أو workforce نفسه. النقطة اللي بعديها كانت to maintain the COVID response just in case if future outbreaks happens بحيث ان احنا ما نعملش a total hold زي ما حصل في first wave. وفي حاجات تانية كان بنبص عليها برضو اللي هي التريننج لأن طبعا التريننج was significantly affected. وأنا يعني I would like also to check with الأصل العيني وطبعا هشام في أمريكا how this also had this impact on the training. والنقطة الرابعة كانت إن إحنا we are in a state of continuous auditing of all the pathways to make sure that if we can improve to increase safety and efficiency برضه. وآخر حاجة communication was quite very crucial and a game changer. لأن if there is no communication and no update of what exactly we're going to have, especially in this situation was always dynamic. يعني every 48 hours, 72 hours, there was always a change, there was a new update. إن إحنا فاهمين نبقى ماشيين في pathways to provide a safe environment. الكاتيجوري زي ما هشام وأحمد قالوا last time, it was for all the surgical care pathways was 1, 2, and 3, and 4. 1 and 2 were not really affected during the pandemic that much because the trauma, the urgent cancer patients were still being operated on. هي المشكلة كانت في الكاتيجوري 3 and 4. It was reported حتى في النيوز ان احنا we are expecting to reach 10 million BBC. We're expecting to reach about 10 million patients على الwaiting list بتاعت ال NHS by the end of this year. So we had to do something about it. This publication, the study was published في Lancet في مايو. And it is about the mortality and the pulmonary complications in patients undergoing surgery in a perioperative COVID-19 infection. دي كانت international cohort study. It was the main contributor and main publisher was University Hospital of Birmingham. And they have looked at all patients who had treatment or surgical treatment with COVID-19 infection, either 7 days before the treatment or up to 30 days after the surgery. And this was done, this cohort study was done in 235 hospitals in 24 countries. وكل العيانين اللي هو they were included in the study, they had COVID-19 positivity, either laboratory, radiologically, or by clinical diagnosis. where primary outcomes كانت يبصوا على 30-day mortality, والsecondary outcomes كان يبصوا على pulmonary complications which has resulted from this, either pneumonia, ARDS, أو عيان ما كانش المفروض إن هو يبقى post-operatively ventilated. They continued to be ventilated as a result of this complication. And the patients who were recruited were just above 1,100 with a mortality of 23.8%. Quarter of these patients were elective and 3/4 were emergency. In the emergency, 25% mortality. In the elective, it was 18.9%, and that's a staggering figure. لأن overall mortality, as I said, it's 24%, pulmonary complications 51%, ومعظم deaths were due to pulmonary complications. But the staggering figure was that in the elective surgery cohort, the mortality was 19%. When you compare the same surgical procedures or disciplines to the pre-COVID area, it was 2 to 3%. So you are talking about 10-fold increase. So any patient who's going to have a COVID-19 infection in an elective procedure, the possibility of of having mortality would be tenfold rise. So this was actually a very game changer in terms of what we are going to do next. And this was prompted the severe, measures that we have taken to start the elective procedure, including this paper and 12 other papers from China. NICE, which is the National Institute of Clinical Excellence, which is the authority in the UK that puts the guidelines for the medical profession, has published a planned care pathway for all the hospitals, for surgical care, and for even diagnostic services. And the summary for this NICE paper is that you need to form like cold centers. So for example, for Birmingham University, we have 4 sites. So one site was categorically for cold elective procedures. There is no COVID patients in this, there is no emergency, there is no trauma. It is a very, very streamlined pathway where patients have to go through extensive measures in order to be able to have their treatment. Sometimes this is not applicable just to have one site or one center. So if you have even a hot hospital, you can do a cold bubble within this hot. So basically, it's a completely isolated area from the rest of the hospital. وطبعا المeticulous IPC اللي هو infection prevention and control regarding all the basics like hand hygiene with social distancing with cleaning. وكل areas in the hospital, all employees, all patients have to wear masks. في areas اللي فيها aerosol generating procedures زي في extubation والintubation, ITU, theaters, you have to wear the full PPE for the AGBS. وكان برضو حته centralization of services. يعني for example احنا عندنا في center دلوقتي بقى بتاع الجايني والبريست. It was not there before. The reason for this, it's same sex pathways, so it is very easy to control it. قالوا لنا ان احنا we're going to put all the microvascular procedures in one site. وفعلا انا كل الشغل بتاعي اتنقل في another site. كل الشغل
Haitham, I'm sorry to interrupt, but maybe if you could continue with the English language, I mean, for the presentation, يعني keep it in English. We have some non-Egyptian attendants.
Okay, sorry, I didn't know that.
Yes.
Centralization of the services, because the microvascular, for example, microvascular procedures has been moved to another site in order to have all the specialization within this site. And this was basically, it's a very busy slide, but basically there were 2 distinctive pathways, either a planned and elective care pathway or an urgent and emergency care pathway. And what's important is that the patients in the planned and elective care pathway, they have to be asymptomatic, they have to be self-isolated for 14 days, that's including the household, so anyone who's living with them prior to admission, and they have to have negative COVID-19 PCR swab tests. That will not be applied for the urgent and the emergency care pathways. And what's also important in this is that there is absolutely distinctive pathways. You cannot have any crossover cover either in the staff. So staff who are working in the elective and the planned pathway should stay on the elective and planned pathway, while staff working on the emergency pathway will not cross over to the planned and elective. And that's also including the space. So you can't use a space for elective pathway to be used for emergency and vice versa. And also the instruments, and also anything which is physically related to this pathway will stay on this pathway. That was very, very important to maintain. So, and this was subdivided that there will be a red pathway, which is the emergency and the urgent pathways. And these patients will not be self-isolating. These patients will not have a COVID swab. These patients could be either asymptomatic or symptomatic. It depends. We have to proceed with their treatment because it's urgent. It's either life or limb saving. And then we have the green pathway, which is the elective surgical pathway, where all patients will be self-isolating with their household for 14 days. All patients will have negative COVID test, and they will have to be asymptomatic when they arrive to the hospital. Then you have this category, which is in between, which is the amber, which is the yellow. And these are mainly cancer patients, and they are quite very vulnerable, and they should be shielded. So, for example, as an example, if you have a screen-detected cancer colon, that patient will possibly go on the green pathway. If you have a cancer colon patient who is becoming obstructive, then this means that he will leave this pathway and will go to the red pathway. So this group is just hiking between either the red or the green. And finally, what is very important also within these pathways is that we personally, as staff, we get tested. So the staff who are in high-risk areas like theaters, like ITU, HDU, they are tested on every 2 weeks. I'm tested every 2 weeks for COVID-19 PCR swab. And this is just an example of one of the sites where this was a cold bubble inside a hospital. So part of the hospital has been taken for a green pathway. So this is an exit door that has been used for the access in and out. And on the left, you can see the ward. And then above the ward is the theaters, and the theaters has been split. So the patients have go inside through this door to the ward, get admitted, have the procedure, back to the ward, and throughout of this. So they are completely isolated from the rest of the hospital. And in addition to this, all the surgeries and all the disciplines have been categorized into high risk, intermediate risk, and low risk surgery. And the reason for this is to try to make sure the possibility of patients getting pulmonary complications and whether they will be on the strict self-isolation pathway or not. So for example, the low risk surgery, they usually self-isolate only for 7 days and they have only one COVID testing, while the high risk and intermediate risk, they would go for 14 days and they have 2 COVID-19 tests before surgery. So if you have a patient who's either on the waiting list or he's been recently diagnosed and been admitted in terms of that he will have surgery soon, he has all the usual preoperative assessment and usually starting with telephone pre-assessment. And if he requires any investigations, radiological, laboratory, as usual, the standard usual pathways. Once this is confirmed, the booking team would be aware about this patient and will confirm a date for the surgery, putting in consideration the self-isolation period. And this is the pathway or the algorithm that we have. As I said, the booking team, once they received that this patient A, for example, will have this procedure and it's in the intermediate or the high risk, they will call him, they will go through the screening questionnaire, they will make sure that they have had no symptoms in the last 7 days. They will tell him that you need to self-isolate for 14 days with your household members, and they will day 10, they will send a text reminder for him to come in day 11 to have a drive-through swab test. On day 12, they send the result to us and the patient, and they also send another text reminder for day 13 to have the second COVID-19 test. Day 14, they tell him the result, and if everything is negative and he's still self-isolating and he did not develop symptoms, then this means that he will proceed for his surgery. And they have a link which they send to their smartphones where the patient will download a smartphone app. And this is to keep tracking of the symptoms. So if he's symptom-free, then he's continuing in the pathway. If he develops any symptoms, then he needs to report to the booking team so that either they defer the procedure or the investigation that is going to be happening. And as I said before, it's the whole idea is not just the patients, it's also the staff. So as I said, we are tested, we have the full PPEs in the designated areas. And for example, for nurses, they have also more complex type of screening and reporting. So they have like a pre-shift symptom reporting questionnaire. They also have a link which is downloaded on their app on the smartphones, where they will be reporting. If they're symptom-free, they will come to work. They will have all the required PPEs. If they have symptoms, then they will have to report to the occupational health, and they will have a viral PCR swab COVID-19 test, and they will have to self-isolate for at least 14 days. In addition to the staff, so this is for the staff also, they have sent a questionnaire to all staff in our university hospitals to categorize the staff into low risk, so staff that will possibly not get infected, and medium risk, and also high risk. so that the staff who are identified as moderate and high risk are special measures are usually taken to an extent that in the high risk group of the staff, they are shielded. So it means that they do not come to work and they have 3 months of shielding. And these are like staff who have previous cancer, who had are obese, who have asthma, who are from the minority. So I'm not sure and in the States if it's the same or not, but we have the BAME, which is the Black minority. There is good evidence that they are more prone for COVID-19 pulmonary complications and possibly mortality. So this is very important. So we cover the patients and we cover the staff also for the safety in order to ensure the safe pathways for both staff and for the patients. In addition to this, we had other measures to decrease the hospital footfall, like we are using now, as we are all experiencing now the telemedicine. There's quite a significant change in terms of how we are conducting our consultations with the patients, our meeting with our colleagues, like virtual clinics, either phone conversations or video consultations. We have the multidisciplinary team meetings now, all done like we are doing today through, for example, Zoom or Video Connect. So that's becoming a game changer, I have to say. And actually, all the staff and the patients are, loving it, to be honest. In addition, we are starting next month to have the artificial intelligence technology in some of our scanners, like, for example, in the breast screening. So we had two radiologists who usually report the breast screening, and another two radiologists who would validate the result. Now we have only one radiologist, or this is going to be the plan from next ones, where the software of the scanners would actually give us a preliminary report, and it's only validated by one radiologist. And again, this is also to make sure that we are providing more capacity, we are more efficient, and decreasing the footfall of radiologists on the hospital. Staff configuration, I think Sham and Ahmed has very nicely highlighted this last time about working in teams. So one team is working, another team is not working, in order, especially if you have fluctuation in the infection rate. So basically, the one team is working, then rest, then the other team comes in. Especially if infection happens to one team, then the team would get as a backup for the first team. And this is, for example, we have 4 microvascular surgeons for breast. 2 are working weekly, and the other 2 are not working. So again, if something happens to the 2 working that week, then this means the other 2 will step in, and so on. Recycling of the workforce. So there are been mobilization of work staff, nurses, healthcare assistants from one area to another area, since some of the disciplines, not necessarily surgical disciplines, but their work has stopped. So we have a workforce that is not working. So again, the recycling of the workforce according to the need was something that we implemented, and also making sure that we are not having all the stuff coming at the same time. No, you are getting stuff, 50% of the stuff coming to work and the other 50 waiting in case that they are required. And also we introduced some, and actually we are starting this month in the introduction of some innovations. So we are starting using MacSeed or MacTrace, which is metal capsules that are inserted into the body, either at the site of the tumor or for sentinel lymph nodes. So this means patients are not required to come to the hospital to have wire-guided localizations and, for example, sentinel lymph node biopsy radioactive injections. These could be done remotely, and also at the same time they don't need to come to the hospital, and it can be done quite a while before the surgery, because it can last up to, I think, 4 to 6 weeks, as far as I understand, because we haven't used it yet, or the breast team hasn't used it yet. It's been used in the skin by the skin oncology team for the melanomas and the skin tumors, but it's still not used in the breast. It has been used some other centers in the UK, but we are going to be using it hopefully this month. And then the training. So all the trainees and the middle grade, definitely there has been quite a significant decrease in the training, which is quite very frustrating for them. So what we have done is that we put all the trainees in one rota. So we had teams like the breast reconstruction team, the hand, the burns. So this model was not the best in this circumstance. So what we have done is that we put all the trainees of all the teams in one local rota, and then according to the activities which is present on weekly basis, the trainees were distributed. We are hoping to go back to the team rota, but I think this is going to take some time because other teams would not be, trainees of other teams would not be exposed that much. So to allow a fair exposure, then we would distribute them accordingly. And also we have feedback from the juniors to see what we can do more for them as much, because this is quite, especially in the university hospitals, which I'm sure also in Egypt and the States, it's quite important that you have to put this in consideration for the future. And then we also, one of the more important factors is that we have been starting to audit all our pathways to see how are we doing, what we can do better in terms of trying to achieve a more efficient and a safe pathway. And this is a correspondence that was sent to us in May to all microsurgical colleagues in the country to participate in an audit to evaluate all the effects of the COVID-19 on free flaps, major pedicle flaps, reimplantations, and to assess when these patients were done in the height of the pandemic, what were the outcomes? It's similar to the one that I've mentioned about the Lancet publication. And we usually receive this performa where we fill all the details, quite a very detailed performa, I have to say. And we fill all this and we send it to the main collaborator who's responsible for this. It's like a national audit, and we are still awaiting we're still in the process of getting all the data, and I think there will be lots of statistical analysis regarding the outcomes, and we are hoping to have this published by the end of the year. As I said, one of the very important parameters is to communicate. And this is David Rosser, communication, who's the chief exec of our organization. And he is, I think he's done a very good job because he's been, I would say daily, and then started to become every other day, that he's sending a communication to all the staff across the organization, updating them with the most recent evidence and recent pathways that are going to be implemented, so that everyone is aware what exactly is happening, which makes a big difference in terms of our response in this very unusual circumstances. This was on Thursday, so there is a slight tentative approach in terms of that there might be a second surge. And actually, if we see in the news that Spain, Germany, France, and Italy, there is a slight increase in the infection rate. So we have the R value, which is the value that determines whether the infection rate is going to be increasing or decreasing. And so long as it's hovering below the 1, we are okay at the moment. But we had several cities in England and in the UK that has been locked down. So we had Leicester, and on Thursday, they said that Aberdeen is going to be locked down because there is an increase in the infection rate. There's a possible outbreak, which can cause a rise in Europe with a possibility of a second wave. So this means that policies needs to be innovative, dynamic, flexible. We have to be very flexible in terms of changing. And I think Dr. Tariq was mentioning earlier about changing the plans of pathways according to the economic, situation. So this is what I mean. You have to be flexible, and you have to be ready that you change your guidelines according to what's happening, either locally or nationally. And you have to be, the plans and the policies need to be logistically deliverable to minimize the risk. So this is again on Thursday. So as I mentioned before, the National Institute of Clinical Excellence has mentioned that there is a national, 2 weeks isolation. Now it has been thrown to us back that they dropped this national 2-week isolation for all elective surgeries. And what they have said is that the local authorities will be responsible according to the local infection rate to decide the self-isolation period and to decide the testing, the tracing, and the tracking of the infected patients. That is what's going to be happening with the local authorities. And actually, this happened to me because on Thursday they've implemented this new rule. On Friday they called me. We have a list next week. Can you get one of your long waiters in? Because now with the intermediate risk, which most of my patients are in the intermediate risk, I can self-isolate them for 3 days only, so long as they don't have any other comorbidities. So they will have, so the 14-day self-isolation is not going to be the rule for all patients. But again, as I said, it's a dynamic, it's a flexible, you have to be ready to change your policies according to the local guidelines. And this is again, the summary of what I've said is that the local areas should decide on the policies. It should be a very flexible approach, and more decisions on resuming services should be deferred to the local leaders. And that is why, again, what I'm saying about the leadership communication. So who's ever taking on board the responsibility for this response needs to communicate quite efficiently with all the stakeholders that are involved in this response. So the take-home message is that you have to have local guidelines and policies which might be related to the national guidelines, depending on your infection rate, depending on the resources that you have, the restructuring of the premises. So I don't think you will be able to start without self-isolating areas or even centers within the organization into a cold, hot, and even a cold bubble within the hot site. You have to have a very distinctive, clear, streamlined pathways between elective and emergency with no cross cover. And you have to maintain, definitely, this is basics, maintaining all the IPC, the infection prevention control strategies, which is masks, hygiene, and social distancing. The patients to be tested, staff to be tested, especially in the green pathway, and also the staff reconfiguration and the staff recycling. I think it's quite very important to make sure that we maximize the training for the trainees, because it is quite significantly affected, at least in our organization. We are trying as much as we can to make sure that the trainees are exposed as much as possible. And as I said, and this is a very, very important thing, is the leadership communication. And finally, the audit is very important, auditing all the practices, the pathways, seeing what's been done good, what requires more input based on evidence-based. And also, for example, we have a special officer who's responsible of getting all the international data and then in implementing what's been done internationally within our policies and to see if it works with us or not. So this is again something which is advisable to take it on board. Thank you.
Thank you to Haytham for such an eye-opening presentation and interesting change of events. Now for the discussion, but before we shift to that, I'd like to welcome the rest of our panelists. Our Professor Dr. Khalid Makin, Professor of Plastic Surgery, Cairo University, and Chief and Head of Department of Plastic Surgery Division, Cairo University. Also, we have Dr. Ahmed Afifi, Professor of Plastic Surgery, University of Wisconsin, with us. Now to move to our discussion. Dr. Tarek, would you like to start?
Good evening, all. Okay. Welcome to our webinar with our distinguished guest, Dr. Haytham Khalil, my dear colleague and friend, and I welcome Dr. Shams Saifi and other colleagues from other universities all over Egypt. I think Haytham had a great presentation about the regulations of the United Kingdom about the COVID-19, and I think they have a good job. And what's striking me that Haytham said about they can make benefit from the first wave or what happened to the second wave. And I think this is a great opportunity to learn all over. And thank you for participation, and thanks Haitham for this. Okay, Ahmed, welcome.
Thank you, Dr. Khaled. Dr. طارق.
دكتور مأمون يا أحمد.
دكتور مأمون حضرتك معانا دي. طيب دكتور طارق بس عشان مأمون disconnected. نبدأ مع حضرتك.
طيب.
اتفضل.
وطبعا أنا يعني I'm really impressed من البرزنتيشن بتاع هيثم، وطبعا البرزنتيشنز اللي قبل كده هشام الصيفي وأحمد عفيفي. يعني حاجة يعني منظومة متكاملة بكل ما تعنيه الكلمة. احنا بعيد جدا عن الكلام ده، وللأسف محتاجين نبذل مجهود ضخم جدا عشان نقدر ان احنا نستعيد الاكتيفيتي بتاعتنا بطريقة مظبوطة وبطريقة علمية كويسة وبطريقة آمنة. انا ما عنديش تعليقات كتيرة، ولكن احنا يعني برضو احنا we have to consider ان احنا مش بس مستشفى ومكان تريننج، احنا كلية فيها جزء كبير جدا من الاكتيفيتي بتاعتها يختص بالامتحانات والتدريب والتدريس والتعليم، وبالتالي احنا هيبقى عندنا مشكلة اكبر في ان احنا ازاي نعمل استعادة للاكتيفيتي بطريقة مظبوطة في كل هذه الأنشطة، مش بس في السيرجيكال اكتيفيتيز. هو regarding الالكتيف سيرجيكال اكتيفيتيز، يعني احنا دلوقتي الكيرف بينزل، لكن في احتمال ان هو يحصل سكند سيرج، وبالتالي يبقى احنا لازم نعمل حسابنا ان احنا ممكن نبقى معرضين في اي وقت ان احنا نرجع تاني. دي هل هنقفل زي ما قفلنا ونوقف كل الانشطه، ولا محتاجين بقى ان احنا نعمل interchangeable او خلينا نقول adaptive surgical plans على حسب الوضع اللي احنا هنبقى فيه. والكلام ده مش بس على الكوفيد، ولكن على اي حاجه ممكن تحصل طارئه او unforeseen events غير متوقعه انها تحصل. انا زي ما قلت هتكلم ان شاء الله المره الجايه على الابلكيشن بتاع الكلام ده على البريست ريكونستراكشن بتفاصيل شويه، فانا مش هكمل في القصه دي دلوقتي. لكن احنا محتاجين بقى كمنظومه تعليميه ان احنا نكونسيدر modifying teaching modules for undergraduate and postgraduate، ودي طبعا نقطه لازم نحاول ندرسها ونشوف ازاي نوصل لها. modifying conventional scientific activities زي ما احنا مثلا بنعمل دلوقتي، هل هنرجع تاني للconventional activity اللي كنا بنعملها، ولا احنا هنستمر بنفس الطريقه سواء في الريجولار ميتينجز او في الانريجولار ميتينجز او حتى في الكونفرنسز على مستوى الكونفرنس والسيمينار. النقطه الاخيره اللي هي الامتحانات، يعني هل احنا الامتحانات برضو هنفضل ماشيين بالطريقه التقليديه اللي احنا ماشيين بيها، ولا احنا محتاجين ان احنا نعدلها؟ والتعديل ده مش هيبقى تعديل مؤقت، ولكن هيبقى تعديل شبه دائم تحسبا لان ممكن ده يحصل وانت على ابواب امتحانات، فانت يبقى عندك دايما النموذج الجاهز اللي انت تقوم مطلعه من الدرج وتبدا تطبقه فورا، ما تحتاجش ان انت تبدا تناقش القصه من الاول. انا الحقيقه بشكر جدا هيثم، انا استفدت جدا 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 من المحاضره دي فوق ما كنت اتصور الحقيقه، يعني محاضره رائعه. وطبعا الاستفاده كانت في الاول من هشام وحبيبي وكلهم زملاء اعزاء، وربنا يبارك فيك. شكرا.
شكرا دكتور طارق. دكتور مأمون، يا ريت اسمع ريفلكشن حضرتك for both discussions النهارده والحد اللي قبل اللي فات. حضرتك what do you think؟
سامعني يا احمد؟
سامع حضرتك دكتور مأمون.
اوكي سامعني؟ طبعا thanks first go to طارق وخالد for arranging these two very nice Zoom meetings, very useful, very scientific, issues ignored by a lot of us. They just put lights on things we were missing or not noticing enough or giving proper attention. So thanks for the plastic surgery department at Qasr Al Aini for arrangements of these two meetings. Of course, last week we listened to Hisham Ahmed from the US experience. This week, Haytham's experience in the UK. Actually, they give us a lot of information. Unfortunately, we are far away from the teamwork they have the golden chance that they adopted in UK and US, but at least we are trying to resume our normal activities. I will not talk about the university, but I'll take it from the private work, and the other part is the educational or training part in the Egyptian Fellowship and the Arab Board, which is I'm in charge of. So concerning the private work, definitely we'll try to follow the guidelines they all give us last week and this week. We'll try to adopt as much as we can what we heard from them. Not sure we'll be able to adopt it 100%, but I'm sure we'll do our best to be safe for us and for the patients too, and for the rest of the hospitals staff. They have to take more care about the situation. Hopefully, not a second wave will happen. I don't think we are capable to suffer again from the lockdown. That will be a disaster to us. So hopefully it will pass like the first wave. It wasn't bad in Egypt. Hopefully if there will be a second wave, it will pass in the same way. The most important part for me is the educational part. Since I'm in charge of training of a lot of residents in the Egyptian Fellowship and the Arab Board, actually what we did from the start, we know that we are suffering. There are two different systems in the Egyptian Fellowship. We have Egyptians and non-Egyptian residents. The non-Egyptians were given obligatory vacation. They are not allowed to enter the Ministry of Health hospitals, so they were staying at their homes just watching. On the other hand, the Egyptian residents at the Egyptian Fellowship, half of them were recruited by the Ministry of Health, where they used them for the triage of the cases coming to the isolation hospital, so their training was zero. The other half, I just helped them by, they have a logbook, they have to fulfill it or fill all the things, so I just recruit all of them in the emergency and the burn department and consider this is the part of their training, trying to minimize the damage. But the problem now is that we have, residents first year, second year, third year, fourth year. Those in the fourth year who are subjected to be examined next month. Definitely, they lost at least 3 months of training, depending on what part is missed for each one of them is different. So the deal we went to is that we will consider it as an emergency situation. So they will go to the exam, and any one of them who is missing a part of his training, suppose this 3 months was supposed to be in the microsurgery training, was supposed to be in the head and neck training, in the pediatric, will try to compensate it after they finish the exam. Of course, they are not obliged to do this, but we are trying to push them to fulfill the lookbooks. So we will keep the result of the exam till they fulfill the lookbook. On the other hand, for the Arab Board, most of the candidates actually were from Iraq, and they were very keen from the start to just shift all of them to the emergency department, hand surgery and burn, and those doing oncoplastic surgery, which didn't stop during the COVID-19 crisis. The problem is that they put all of them in the emergency department and the burn. So instead of having one resident for the emergency cases today, you have two. So the training is divided into halves. For those who are in the first 3 years of training, they will have to, for the next year, that they have to compensate for what they missed. Those at the final year, they are the real victims. They have to pass the exam within the next 2 or 3 months, and then we'll have to see after that how can we help them to compensate for what they lost. I need to know from Haytham and Hisham and Ahmed Afifi what they're going to do for the residents training. Thank you.
Thank you, Dr. Amoun. Maybe you could start with Dr. Hisham Safi.
شكرا ميرسي دكتور احمد وثانك يو again to Dr. طارق ودكتور خالد ودكتور مأمون طبعا for inviting us. Haytham, it's a great presentation. I have a couple of questions for you, بس قبل ما انسى النقطة اللي الدكتور مأمون اتكلم فيها very very important. النهارده الصبح I was part of the meeting for the academic program directors on the East Coast, on the West Coast, اللي هم Stanford, UCLA, UCI, وكل ال UCs يعني. And the concern طبعا is going to be the COVID. how can we do the interviews, how are we going to do the training, the effect on the training, how would that go for the future. ففي افكار يعني جديده بنطلعها، وفي حاجات بالنسبه للانترفيوز. الانترفيوز دلوقتي are going to be virtual. يعني ما فيش زي زمان انه you go, you travel and then you meet someone for an interview and then they can come and spend a week with you. All these will be very limited. But on the other side, the good news is one of the ideas that came today is to combine all the academic didactic programs, يعني grand rounds for all the UC system. يعني بتوع ستانفورد و UCSF و UCLA و San Diego، كل الناس دي which is the major programs of plastic surgery in the country will be combined. So you can all log in. فواحد من UCSF في San Francisco can log into San Diego and then become part of that. So that's going to be great. I mean, hopefully that we can, maybe in Egypt, I don't know if it's feasible, but something that can come out from the COVID. But there are some negatives, but then obviously there will be some positives on the educational part. احنا بالنسبة لنا for the small fellowship we have with ASAPs, it's becoming a little bit harder لأن احنا we cannot interview برضو in person. So it's يعني we have to rely a lot on the CV and then on the virtual interviews and so forth. هيثم قبل ما انسى اولا great presentation again, thank you very much, very enlightening. بس ال study that you quoted, this is early in the COVID infection when PPEs were not that common, the protocol was not clear, and these patients were not tested by PCR with a 25% mortality rate.
Yeah.
What do you...
Yeah. That study was published on the 29th of May, and it took, so basically it was in April, so I think it was around possibly 6 weeks, 6 to 7 weeks, where they got all the statistical analysis and they published it. I think because of this related to COVID, it was fast-tracked for publication. It took only 10 days for that to be published. But if you look at my presentation at the beginning, there was the Martin Richardson, who's the divisional director. So basically, he's like the third man from the hierarchy point of view, and he used to give us the briefing for senior staff in the university. And this was the data that prompted us to start looking into measures. You're absolutely correct. Maybe if we do, and I mean, we are involved in lots of trials, and I'm sure you on your end also, there's lots of trials which is happening locally on a national and international level. But I think the outcomes might be different now. If you do the study now on COVID patients, I personally had 2 patients, complex patients, that are going to be involved in the audit, for example, doing complex free flaps in patients who had COVID infection. And we are waiting for the outcome of this. But I personally, in 2 complex cases with COVID infection, they were fine. Again, I can't, that's anecdotal evidence that, you will have this mortality. But I think when at that point, when you see the staggering figures of 10-fold increase, if you go and do a patient, for example, with a breast, let's say a breast cancer, for example, and you're doing a mastectomy and a reconstruction, and you're going to be telling the patient that you have a 10-fold increase for a patient, because the mortality in these patients is less than 1%, and you tell her that you have a 19% mortality. I think this has prompted us really to take very severe measures. It's like, the Nightingale hospitals, the one with the 3,000 or 4,000 beds. It's only 2% has been used. So I think the response was exaggerated, looking at it in hindsight. But at that point, you can't do this. Does that make sense? So you can't act on these data. Now that's why again I said the auditing. So now we are auditing more. We're getting more data. We're getting more statistical analysis to this data, so that we can define. Like for example, and I was really surprised, and I thought about you and Ahmed on Thursday when they rang me and told me, oh, now we're doing it 3 days, because I asked you this question last time, and I remember you telling me 3 days, and I was really, there's quite a significant difference between what's happening in the US and between here. And now we're back to what you're doing, guys. This based on the comorbidities and all this stuff. So I think you're absolutely right. I think if they do the study again, we might have different figures, which I think it should be done. And we are waiting for more data to come in to modify our policies and guidelines.
Something very quickly. So yes, I totally agree. 3 days been working really well. There is an ongoing study at the national level and in the local level, and some of the numbers were announced yesterday, and I think the mortality is less than 1%. But again, for these elective patients with no symptoms, negative PCR, the 48 hours to 72 hours is working very well. The only problem we're getting to in California, and I'm looking forward to hear from Ahmed, is that sometimes we can get these results on time. And so many people are doing it. Now the labs are overwhelmed. So now we're looking into the rapid test, which gives you the result in an hour. So yani, now maybe we go back being like Britain again. No, I think we'll continue the 72 hours, but it's a little bit tricky. But thank you, Haitham. Thank you very much. I appreciate it.
Thank you.
Thank you, Dr. Hisham. Dr. Afifi, we'd like to have your perspective in University of Wisconsin regarding the training of juniors and even with seniors. How do you deal with that?
طبعا اول حاجه سلامي لكل اساتذتي وكل حبايبي اللي معانا هنا، للجيل الصغير اللي فيكم ما شافش هيثم بيشتغل. هيثم هو واحد من اشطر الجراحين اللي واحد ممكن يتفرج عليهم ويستمتع بشغلهم. يعني نعم بقالي 30 سنه بكسبه في السكواش بقطعه كل مره، بس هو في الجراحه اكيد مفيش نقاش في هيثم. دكتور مأمون رد على الكلام. دكتور مأمون، احنا كان عندنا السنه اللي فاتت 4 نواب، فكل واحد فيهم كان شيف لمده 3 شهور. في ال3 شهور دول الشيف بيعمل حوالي 30 ل 40 فري فلاب في الشهور اللي هو الشيف فيها. فيعني ان هو يخسر 3 شهور، خصوصا اللي هم كانوا اخر 2، دي خساره يعني بالنسبه لهم كانت حاجه فيري تروماتيك بالنسبه لهم ان هم ما يبقوش الشيف. بس هم كانوا كلهم خلصوا their numbers من قبل حد ما يدخلوا الشيف يير. فit actually did not affect them. واحنا دلوقتي معظم شغلنا راجع زي ما هو، فمش فارقه قوي. بس انا يعني انا عارف ان اللي بيحصل في البورد، في الامريكان بورد اوف بلاستيك سيرجري، الريكوايرمنتس مش هتقل في اي حاجه خالص. لسه الامتحان بنفس يعني the same rigorous exam, the same requirements، الاورال الريتن فيها تغييرات بسيطه قوي، بس ما زال في الاخر هو الامتحان مش هيبقى اسهل باي شكل من الاشكال عشان اللي حصل في الكوفيد. احنا عندنا هنا رد على الدكتور هشام، احنا عندنا هنا لسه ويسكونسن الانفكشنز فيها مش زي كاليفورنيا، فالتست دلوقتي بيرجع within a week. لما بدينا في مارس او ابريل، يعني by the time they actually get back to us on the phone, it took them like 3 days to just answer the phone and get back to us. But now if you call, they answer, they pick up the phone immediately, you get tested within 1 or 2 days, and the result is back in a week. أنا عندي سؤالين لهيثم. أول واحد هو برضه نفس المقالة اللي هشام سألك عليها. The 25% rate of mortality is يعني staggering. It's actually shocking. And I feel embarrassed that I was not aware of this study. Why is it so high? Is it the infection is more severe? They're immunocompromised because of surgery? They're already sick and predisposed? And this number needs to be analyzed. And the second question is more of a social question. انتوا كان طلع حد من الصحة عندكم اللي هو طلع في أول مارس، اللي هو أول واحد يقول نظرية الهيرد immunity، والناس كلها قالت عليه ان هو مجنون ساعتها. دلوقتي اللي احنا شايفينه في العالم كله ان the second wave is going to happen. يعني I think ان هي ما فيش فيها نقاش. اي حد شايف انها ممكن ما تحصلش يعني I think he's in denial. It is going to happen. وهو كان نظرية الراجل اللي قال herd immunity ان انت you can't lock people down forever. You have to postpone the lockdown as much as you can. وكل الناس قالت عليه مجنون. دلوقتي ناس كتير بتقول لا ده هو actually ما كانش مجنون قوي. انتوا في انجلترا شايفين ايه؟ شايفين ان the lockdown was too early, was too late? What do you think should have been the right thing to do?
I mean, from the thanks, Ahmed, very much for your comments. I think for the first question, I have a link. I'm going to send it with all the actual paper. It's actually open access paper. You can if you just Google it, you'll find it. And there's loads and loads and loads of parameters that has been and prognostic indicators that has been statistically analyzed to reach this conclusion. But I think from my point of view is that, as Hisham quite rightly mentioned, at that point and in this this period, where our treatment for the COVID infection or infected patients were suboptimal because we did not know a lot about it. And they were just, trying lots of medications, lots of pathways, and there was lots of clinical trials. And I think handling this situation was beyond their, their scope. And that's why the majority of these patients, and you will find like for emergency patients, for example, is higher than the elective, but still the elective is very, very high. And, if you're doing an elective case, you're possibly going to pre-optimize the patient quite very good. But I think the pulmonary complications were the most, 83% of the mortalities. So the 25% mortality, 83 of these 25% died because of pulmonary problems. And again, I think it's premature to say that this is always going to be due to pulmonary complications, because I think now, I'm not sure, but we don't have lots of admissions in the hospital now. So, and the death is even quite, we have about 30, 40 patients. Yesterday there was 30, 40 patients from staggering, thousands as we previously had. Admissions, we have very few, and the majority of the admissions are also just being taken, just in consideration for being cautious. But they are not really sick or ill, or either they don't require ventilation. So I think the main reason for the mortalities was mainly pulmonary complication, ARDS, pneumonia, was the main factor. Regarding the second question, with the herd immunity, this guy, you're absolutely right. They thought that this guy, if he gets it wrong, we are going to be in deep trouble. I think the lockdown, the majority in the UK, they feel that the lockdown was done late, and it should have been implemented earlier than that. Especially that we are the West European country, so we have all total 56,000 deaths. We had time. It's not like we are like in Italy, or Germany has done better than us considerably. But I think, and this is why the response that I've said in COVID, in the phase 1, our response was very poor. And that's why they wanted to get things right in phase 2. And that's why they've done all this. But I think the lockdown, the people think that it has been implemented late, and it should have been implemented before that, especially had lots of time when you compare with other countries who are hit straight away, like Spain and Italy. The herd immunity, I'm convinced with the herd immunity, but I'm not sure about the mutation of the virus, because there is some talks about the mutation of the virus. By the time you reach the herd immunity, you have a mutation of the virus, which starts another outbreak. So I'm not sure if someone has an experience in this, can give us a more insight in this. But I think it's definitely the lockdown was, they think that it's been implemented late rather than early. It should have been implemented earlier than that.
I think to Raitham, regarding the virus mutation, we've heard a lot of maybe called rumors. I haven't read anything documenting there are different strains maybe for the virus. I'm not sure of that, but I'm not sure which way we should go right now. And I think, Dr. Mamoun, I'd like to go back to your question and your experience regarding the training of the juniors. After hearing Dr. Afifi, Dr. Hisham, and Dr. Haytham as well, what do you think now regarding resuming the regular training for the Arab and the Egyptian fellowships of plastic surgery? What are you thinking? When would you resume the training, the regular training?
They are supposed to start next week, Ahmed. In the Ministry of Health here, they will start resuming the training program for the residents. Actually, I take from Hisham what he said. We get only positive part that the residents spend most of their time listening to and attending webinars and Zoom meetings. Hopefully, this theoretically will compensate some of the clinical part they lost. They will start next week, and I hope at the end we'll try to compensate for what they missed during the last 3 months.
Okay, thank you. Dr. Yusuf Saleh, you have with us for your word and your experience with the training. Dr. Yusuf.
دكتور احمد
اتفضل يا فندم.
السلام عليكم. متشكرين
وعليكم
للدكتور خالد بيه والدكتور مأمون بيه والدكتور طارق بيه لتنظيم الويبينار ده لحضرتك، وطبعا اكسلنت برزنتيشن للدكتور هيثم بيه، طبعا ربنا يكرمه. بس انا عندي سؤال للاساتذه في الجامعات، لان احنا انت عارف بدأنا في مصر دلوقتي ان الطلبه تدخل امتحانات الماجستير والدكتوراه اللي هو دور سبتمبر. ايه الخطه اللي ممكن نمشي عليها؟ لان هل في عيانين هيجوا ولا لا؟ هل هيبقى الامتحان سلايد بيز؟ هل هيبقى في مرضى اون كلينيكال بيز؟ يا ريت الكلام ده يتوحد على الجامعات، عشان انت عارف احنا عندنا الشهر الجاي على طول امتحانات الماجستير. فكنت حابب اسمع راي دكتور خالد، الدكتور مأمون، الدكتور حلمي، اساتذه من الازهر في هذا الكلام، لان احنا عندنا فعلا مصيبه اسمها امتحانات دلوقتي، ومش عارفين او نقيم الطلبه ازاي.
انا هرد عليك يا يوسف في النقطه دي. هو المجلس الاعلى للجامعات خد قرار نظام الامتحان ومواعيده في البوست جراديوت، كل جامعه هي حره تحطه ازاي. هو ما اداش يونيفرسال اجريمنت للقصه دي، واحنا في القصر العيني ما زالت في بعض الاختلافات الجذريه في الاقسام يعني على how to do the exam. هل هو زي ما احمد كان بيقول عفيفي دلوقتي ان الامريكان بورد بتعمل ما فيش تشينجز تقريبا حصلت فيها خالص، لكن احنا وجود الكلينيكال اكزام مفروض يفضل موجود على الاقل في الدكتوراه. بس كل جامعه هي بتادوبت التكنيك بتاعها يا يوسف، يعني هي ما فيش يونيفرسال اجريمنت غير في حاجه واحده بس، ان احنا هاف تو اكزامن دورين، اكزامن في سبتمبر اند ذن ري اكزامن تاني في شهر 11 الدور الثاني. لكن كل جامعه بتاخد انا شايف ان احنا مع البريكوشنز الكويسه جدا احنا وي كان دو ذا اكزام نيرلي ذا سيم، يعني من غير تشينجز دراماتيك يعني في حاجه. بحب اسمع راي الاساتذه اللي معانا يعني.
احمد سامعني يا احمد؟
دكتور مأمون اتفضل يا فندم.
ايوه بص خالد، انا هقول لك على الاقل اللي هنعمله في الزماله، عشان احنا عندنا برضو امتحان يمكن اخر الشهر ده، فاحنا للاسف طبعا ما فيش حالات في المستشفيات، فهنعمل الحقيقه الاكزام اوسكي واوسبي، هو ده اللي احنا هنعمله من غير صور حالات rather than patients، هو ده اللي هنقدر نعمله في الامتحان الزماله. البورد العربي خدنا قرار ان احنا عندنا كان فرصه اجلنا الامتحان لديسمبر، وقلنا هندي فرصه لحد اكتوبر، لو الدنيا ما اتحسنتش هيبقى الامتحان يتاجل السنه الجايه، لانه ده ناس بقى بتيجي من كذا بلد ولازم تتجمع. ده مبدئيا القرار اللي احنا خدناه.
دكتور طارق حضرتك ليك انبوت يا بيه؟
يعني هو الحقيقه انا بس هنا في تحفظ شويه على فكره ان احنا نعدل نظام الامتحان فور وانس، لان ده بيعمل unfair game لمجموعه من اللي بيمتحنوا على مستوى مثلا السنتين الجايين. واحد دخل في امتحان ظروفه الكويسه جات ان هو عشان الظروف دي فالامتحان بقى سهل فنجح، وبعدين واحد تاني دخل المره اللي بعديها والامتحان رجع للطريقه التقليديه فكان صعب فسقط. ويعني القصه الحقيقه يعني انا شايف ان هي unfair. احنا عندنا مثال اليومين دول امتحان بكالوريوس، كنت لسه النهارده في الكليه قالوا ان الامتحان اللي اتحط ده لو حد تمريض جه يحله هيحله، يعني بمعنى ان انت هتخرج دفعه بتقديرات عاليه جدا ومجاميع عاليه جدا هتطغى على اللي قبليهم واللي بعديهم، سواء على مستوى القصر العيني او على مستوى المجموعه العامه اللي بتبقى بعد كده بتتحط في كومن بول لما بيجوا ياخدوا نيابات في وزاره الصحه. الحقيقه انا شايف ان احنا لازم نعدل المنظومه بحيث ان هي ما تبقاش فيها abrupt change، يعني المره دي هتبقى دروب وامتحان سهل وامتحان اي واحد ينجح فيه، والمره اللي بعديها نرجع للنظام العادي، وبعدين يحصل مره تاني كرايسيس نقوم راجعين عاملين دروب. طب واي نوت انها تبقى فرصه ان احنا زي ما بنقول ان احنا بنعدل الموديول بتاع التيتشنج والموديول بتاع الساينتفك اكتيفيتي، طب ما احنا نعدل برضو الطريقه بتاعت الامتحانات بحيث ان هي تبقى more or less standard، يعني ممكن نوصل لها بكيرف معين نطلع بيه، مش لازم نوصل لها مره واحده، لكن اتليست لازم نحط في اعتبارنا العداله المطلقه لمجموعه طلبه هتدخل في خلال سنه او سنتين. ده وجهه نظري.
شايف يعني الامتحانات تتاجل لغايه لما نظبط كيرف
انا كان رايي اصلا الامتحان الدور ده بتاع الدكتوراه ما يتعملش، يعني ما كانش فيه داعي ليه، لكن خلاص احنا جالنا تعليمات من الجامعه وتعليمات من الكليه ما نقدرش ان احنا نشذ عنها، فالدور ده قائم. ولكن انت هتعمله بطريقه، انا اي ثينك ان احنا الطريقه اللي هنعمله بيها لازم تبقى قريبه جدا من الطريقه اللي بعديها. يعني ما نجيش نعمل الامتحان ده بطريقه وبعدين نرجع للنظام التقليدي مره واحده في الامتحان اللي بعديه. لا خالص، احنا نعمل بطريقه وبعدين الامتحان اللي بعديه يبقى قريب جدا منه، وبعدين نستابلش بقى موديول للامتحانات بيختلف عن الطريقه الكونفنشن، عشان احنا معرضين ان ده ممكن يحصل تاني او حاجه تانيه تحصل او غيره يعني.
كلام منطقي. دكتور هشام معاك، حضرتك معانا؟
معاك يا دكتور. مساء الخير على الجميع. شكرا يا دكتور هيثم على المحاضره الرائعه. انا بس يعني عندي نقطتين هتكلم فيهم. زعلان قوي من ان احنا هنتنينا كل ما نحضر ويبينار نقول ان احنا بعيد قوي عن. طب لحد امتى يا دكتور خالد بيه هنتنينا بعيد؟ احنا حضرنا الويبينارز 3 4 وكل الناس حطت الجايد لاينز، والجايد لاينز موجوده والبيبرز افيلبل والنشر بيوصل لنا، واحنا عندنا اي حد من الجونيورز والسينيورز ممكن يشوف البيبرز ديت قبل ما تطلع حتى على الايجيبشن نوليدج بانك. انا رايي يا دكتور خالد بعد الويبينار الدكتور هيثم هيبعت الجايد لاينز ديت، وحضرتك هتكلف الدكتور احمد صفوت وهتكلف الدكتوره دينا، الدكتور ابراهيم، تيم يتكون من بكره ونبدا نخش في الجايد لاينز دي ونطبقها سواء في القصر العيني في طنطا في. انا صعبان عليا جدا. انا كنت بزور زميل لنا امبارح عامل حادثه وفنتليتد في الاي سي يو. there is no a single doctor في الاي سي يو حاطط ماسك يا دكتور خالد. يعني احنا ما ينفعش، لازم يبقى فيه ريجوليشنز ولازم تبقى طف، ولازم الجيل بقى الدكتور سامح النعماني بعد اذنك يا دكتور سامح، انتوا الجيل اللي جاي لا لازم تحطوا ولازم نبدا. لان للاسف انا قابلت الدكتور فتحي خضير لما كان راجع من انجلترا، كنا في جي دبليو ماروت من 3 سنين لما كان رايح في الميشن ان هو بيعمل توأمه للقصر العيني مع احد جامعات انجلترا، وقال احنا قدامنا 2 3 عشان نبدا نعمل التوأمه دي. خلصوا 3 4 سنين وهنفضل برضه نقول احنا لسه بعيد. دي نقطه من ناحيه، يعني انا معترض على ان احنا لسه بعيد. لا، احنا من بكره we have to start guidelines ونبدا نحط دي ونبقى فيري ريجن. بالنسبه للامتحانات الدكتوراه احنا الاعداد عندنا قليله يا دكتور خالد بيه. الدكتور يوسف انت عندك 2 العيانين بتوع الكانسرز ما همش ما اختفوش، احنا لسه بنشتغلهم لحد النهارده. العيانين بتوع الريكونستراكشن موجودين، فانت ليه عايز تو شيفت دكتور الدكتوراه او يعني الكانديديت اللي هيمتحن الدكتوراه مش عايز تمتحنه كلينيكال ليه؟ هل في صعوبه ان احنا نوفر 2 كيسز او 3 كيسز نمتحنهم عليه؟ وزي ما بيتقال يعني ايه احط امتحان لطلبه بكالوريوس التمريض يحله واطلع طالب مش افيشنت؟ فهي يعني زي طالب الثانويه العامه 60% من الطلبه جايبين فوق ال 97% لمصلحه مين؟ فانا شايف ان هو يعني ايه، احنا يعني رايي ان احنا نعمل زي الدكتور احمد عفيفي، مفيش تغيير كبير ولازم نتحرك في الحيز بتاع ان احنا ما نضرش الكانديديتس، بس ان احنا نوفر لهم الحمايه الواجبه وكذلك الحمايه الواجبه للممتحنين، لكن ما ننزلش بمستوى لا الخدمه الطبيه ولا بمستوى الامتحانات على اساس ان احنا في الكوفيد ايرا ويطلع بقى جيل في 2 3 دولت مختلف عن الاجيال اللي قبل كده والاجيال اللي بعد كده. شكرا حبايبي.
شكرا يا فندم. سريعا كده ايه دكتور طارق، هناخد دكتور ماجد المفتي، يا ريت يدينا الانبوت بتاعه قبل ما هترد. دكتور ماجد بيه.
اوكي. Thank you Ahmed. Thank you Professor Khalid and thank you Professor Mamoon for organizing this webinar, which is very important, and I'm very grateful for the participants for the last webinar and this webinar, Professor Hisham Saifi and Professor Haytham Khalil and Professor Ahmed Afifi. Practically speaking, I think that COVID-19 is here to stay. So whatever we do, I think it will be permanent changes, because as we know, or as it is said now, that we don't know, even with the advent of the COVID-19 vaccine, we don't know whether it will be effective and will give long-term immunity, or it will be like a flu vaccine that has to be changed every year. So practically speaking, any change that we do, we have to make it permanent, including the changes that we have to make in the examinations, education, and training, and the aspects of dealing with the patients and whatever. The most important point is in any of these activities is the gathering of the people. Now we're even in examinations or training, we have to control these gatherings. We have to make smaller groups in the exam or in the training. We have to keep it in a safe way. But I think that changes will have to be done, and it will be permanently changed. It will not be only for this couple of coming months. It will always be at least for a couple of years until the bigger picture will be more evident. So regarding the exams, I think that one of the things that we have to take care of the large numbers of the people attending the exams and how we circulate around them, and we have to put a protocol for that. Until now, there is no unified protocol from the Ministry of Health to implement the rules for safety of COVID-19 during this pandemic for the activities of patients, and for the activities of training, and for the activities of the teaching. And we have to sit down and implement these rules. And I think these rules will be for a long time, because as I've said, that COVID-19 is here to stay. I don't think it will go away for the next couple of years. And even if there is a vaccine, we don't know if this immunity given by this vaccine will be permanent or not. Again, thank you very much, and I urge everybody, especially the Higher Council for Education, to implement a protocol, unified protocol for the exam. Thank you very much.
Thank you, sir. One last thing before Dr. Atif, Dr. Mamdouh, دقيقة واحدة لو ممكن. I want to say something that before we started this meeting, I was talking to Dr. Haytham, and he was explaining to me how the waiting lists on the NHS is accumulating, and there is a pressing need to restart the electives as soon as possible. At the same time, the fears of having a second wave are there. A number of countries around the UK, like he explained, Spain and Italy and others, are having rising numbers. One of these things, things to prove or even to assist in that, I'm not sure, is the screen shared properly? Can you see the NHS letter? So I regularly get these NHS letters for the MRCS. One of these I've received a couple of days ago. Regardless of the second wave, or even with the presence of a second wave, the NHS or the people in charge are pushing for the NHS to restart their activity and resume as much as possible of it. They're pushing for 80% next September and even 100% in October. This need, I think, at the same time of understanding that there is a second wave, goes with what my professor just explained, that the corona or the COVID is here to stay. So I think the NHS is building a system and a way to deal with that, training and managing of elective patients, as well as the need to finish the elective cases and keeping everyone safe still. So I think this is important regarding not only the training and the students' exams, but also regarding the management of the elective lists. Second wave or not, they're pushing to start over 80% and even 100% in October. I think this is it. دكتور ممدوح أبو الحسن، اتفضل.
بخير. اولا طبعا يعني شكرا جزيلا على كل الاتنديز للمحاضره الجميله اللي قدموها. انا بس كان ليا كومنت على موضوع الامتحان. يعني سواء الدكتور طارق والدكتور خالد وكثير من الزملاء بيتكلموا على حكايه البروتوكول بتاع الامتحان مختلف من جامعه لجامعه. يعني احنا دلوقتي في كرايسيس، هل ممكن نستفيد منها ان احنا نوحد الامتحان في الجامعات المختلفه؟ يعني احنا عندنا 20 كليه طب تقريبا دلوقتي او 22 كليه طب. ما فيش فكره ان الامتحان يبقى يونيفايد ويبقى بورد اكزام على ناشونال ليفل، بحيث ان يبقى في ستاندردايزيشن حتى للخريجين كلهم في كل الكليات. يعني مش المفروض ان يبقى في اختلاف بين الخريج بتاع اسيوط، الدكتوراه بتاعت اسيوط او القصر العيني او القوات المسلحه او الكليات الخاصه، خصوصا ان الاقسام التخصصيه بيبقى العدد فيها محدود. يعني شعبة زي التجميل كده على مستوى مصر كلها هيبقى فيه 150 واحد تقريبا بيمتحنوا. هل ممكن الامتحان ده يبقى يونيفايد بالاتفاق بين الجامعات المختلفة، ولا ده حاجة يعني من الآمال الصعبة جدا يعني؟ ده سؤالي طبعا دكتور مأمون ودكتور عاطف.
الإجابة دي مع دكتور خالد مأمون. استأذن حضرتك دكتور ممدوح، بس دكتور عاطف هسمع سؤال حضرتك ونرجع نرد على حضرتك. دكتور عاطف.
الدكتور عاطف انميوتد لسه
كده. اوكي،
اتفضل.
اولا شكر القصر العيني على هذا الويبينار الرائع والتنظيم. بشكر هيثم بيه على الكلام الجميل، والاسبوع اللي قبل اللي فات طبعا دكتور هشام ودكتور احمد. شاكرين يا احمد تصفت مجهودك ومجهودك. اولا انا مع الدكتور هاشم عياد، كنت عايز ارد على النقطتين دول. احنا مش اربط اواي قوي زي ما الناس بتقول. احنا عندنا ستريكت رولز، عندنا جايد لاينز شغالين عليها. احنا ما وقفناش. عندنا ابارت فروم الايزوليشن هوسبيتالز اللي اتعملت دي، الشغل في المستشفيات ماشي عادي. واي ثينك ان بدا العيانين يرجعوا تاني وبدا الدنيا تاني. دكتور هاشم بيه، يمكن انت حضرتك رحت مكان ممكن يبقى فيه شويه يعني ناس مش لابسه، لكن احنا في مصر او في معظم المستشفيات بالريستريكت رولز قوي، والناس كلها واخده كل الاجراءات الاحترازيه وماشيه الكلام ده. ابارت فروم طبعا بعض وعي الشعب، ده قصه ثانيه مختلفه. انما احنا مش قوي عن الكلام ده. احنا وي بيلت هوسبيتال with 3000 مش in 9 days، من less than 5 days، لان احنا بنعمل على طول التريل عندنا في القوات المسلحه وبنشتغل على طول على الكلام ده كله والحاجات دي. فاحنا مش قوي يعني. ده رقم واحد. رقم اثنين، بالنسبه للمستشفيات والامتحانات، احنا في الكليه عندنا الناس شغاله عادي جدا، مفيش مشكله، لان العيانين بداوا يرجعوا وبدات الدنيا ترجع خالص. فيعني اعتقد ان الامور ممكن. وبأيد جدا طبعا دكتور طارق بمحكوم على رايه في ان احنا ما نعملش حاجه استثنائيه المرات دي ونرجع نعمل تاني. الراي يعني ممكن تمشي عادي جدا. العيانين بداوا يرجعوا، كل مستشفى عليها تطبق ستريكت رولز، واحنا مش هنبقى قوي خالص. بشكر الجميع وشكرا دكتور احمد بيه على الكلمه. شكرا.
دكتور عاطف. دكتور طارق، احنا we had a number of questions, a number of experiences presented من اساتذتنا هنا في مصر as well as in the NHS experience and the US experience. At the end of these sessions كنت عايز اسمع reflection بتاع حضرتك عن الموضوع ده. ايه رايك نبروسيد ازاي الفتره الجايه؟
يعني قصدك ان هو انت محتاج تفتح وقت تاني يعني للاجابه على الاسئله، ولا يعني concluding
زي ما هتشوف لو في سؤال شايفه لسه محتاج يعني يتسأل عنه تاني we could do that. بس I think احنا we had the NHS experience cleared with their protocols with their system and the US experience with their feedback والنيد ان هم يرجعوا تاني. واحنا عارفين كويس ان يمكن في second wave.
يعني النقطه اللي احنا محتاجين ان احنا خدنا ال NHS experience من هيثم، وخدنا ال US experience من عفيفي وهشام، وطبعا الامباكت بتاع الدكتور مأمون من الاشراف على الزماله المصريه والعربيه. احنا في الاخر احنا انستتيوشن، يعني ما نقدرش نحط قواعد لينا تبقى خارجه بنسبه عاليه جدا عن قواعد الانستتيوشن اللي احنا شغالين فيه. بمعنى ان احنا محتاجين هنبدي راينا، هنناقش راينا في كوميتي تشمل اسم الجراحه وتشمل الاقسام الاخرى وتشمل اداره المستشفيات، عشان نوصل في الاخر للصياغه العامه اللي كلنا هنلتزم بيها في القصر العيني، مش في اسم الجراحه بس واسم التجميل بس. وعشان كده هو الكلام ده هيبقى سابق لاوانه جدا، ان احنا اوريدي لسه ما دخلناش في الدسكشنز دي بصوره جديه. يعني احنا كلام ان احنا عايزين نرجع نشتغل، وهنرجع نشتغل بطاقه 25%، والطاقه ال 25% دي تساوي ان احنا نقدر ان احنا نشتغل يعني let us say العمليات بالعدد اللي مسموح به، اللي هو الوار سلوتس الافيلبل كلها تقريبا. بس في الاخر ده لا يكفي. طيب ايه بقى البريكوشنز اللي المفروض ناخدها؟ ايه الحاجات اللي المفروض تتعمل للعيانين قبل ما يدخلوا؟ ايه فتره العزل المطلوبه؟ تصنيف العيانين زي ما هيثم قال كده، ريد ويلو وجرين. تصنيف العمليات اللي احنا عايزين نعملها ونحطها في الكاتيجوريز بتاعتها مظبوطه. كل الكلام ده لسه احنا عايزين نقعد ونناقشه، وده كان الفكره من ان انا بقول ان احنا بعيد لان احنا كان لازم نناقش الكلام ده، ومحتاجين ان احنا نحط له القواعد بتاعتنا اللي هي تنطبق على الانستتيوشن اللي احنا فيه في القصر العيني، او الزملاء في عين شمس بالظروف بتاعتهم، او الزملاء في القوات المسلحه في الظروف بتاعتهم. يعني قصدي كل انستتيوشن هيبدا يحط القواعد بتاعته. احنا كنا بنحاول يعني يبقى في ضوء كده بيفتح لنا الطريق ان احنا نسترشد بيه في ان احنا نحط القواعد دي بطريقه مظبوطه، بطريقه علميه مظبوطه. اي هوب ان احنا نعمل الكلام ده باسرع وقت ممكن عشان ما يبقاش عندنا خسائر، وان شاء الله تبقى الامور كويسه في الفتره اللي جايه.
شكرا دكتور طارق. دكتور هيثم, before we finish the meeting I'd like to a conclusion كده من حضرتك برضو. how would you reflect on فكرة أنا كنت بسأل من شوية إن needs of الحكومة والبلد من ال NHS إن هي resume its activity, وحضرتك كنت بتكلمني من شوية إن احتمال كبير في second wave. فهو طبعا حاجتين ضد بعض وبيشدوا عكس بعض, بس حضرتك شايف الدنيا هتمشي إزاي؟ وهل الرولز المحطوطة دلوقتي هتفضل efficiently مفيدة في الفترة الجاية ولا هنعوز حاجات أعلى كده كمان؟
هو أنا 2 weeks ago لما كنت بسمع أحمد وهشام I was a little bit tentative in terms of يعني the US experience is that they're quite very brave. They are opening quite considerably, you know. But I'm sure they have put, you know, everything there is evidence-based, and you know, there's lots of statistics there. We all know that. But now, looking at it from our experience, and I think we're getting more and more experience now in terms of the data which is coming, which is also analyzed. I believe that we should continue on with the concept of opening the services, and I think this is quite very evident from the top level in the government and the Department of Health that they are going to resume. As you quite rightly showed, that we are going to be resuming in the next 2 months between 80 and 90% of the clinical, and I'm seeing it this firsthand in the last maybe 2-3 weeks. And I think it's very important, as Dr. Tarek El, I think, and I'm not sure what is the guideline from the Department of Health في وزارة الصحة ومن الجيش. يعني هل في national guideline طلع؟ Because if there is a national guideline to resume activity, then this means there is a green light and go ahead. It's up to each institution to form the local policies in order to achieve these streamed pathways in the best way to achieve safe and efficient streamlined pathways. So an advisor من let's say من القصر العيني عارف ان في national guidelines طلعت من وزارة الصحة او من الجيش بيقول ان احنا we have to resume the work. That's fine. How we're going to resume it هم بيحطوا يعني a very let's say a general outline, لان every place انا ما اعرفش طبعا infection rates مثلا في مصر, في القاهرة, في اسيوط, في اسكندرية, how it is, it's different or not, but it will be guided by the local. This is the fact now. This is what we have reached. And I think this is quite very evident in the States, where every local, every region is having its own local guidelines, and they're working on it. It's quite different from the west or to the east of the US. It's now, this is going to be the trend with us now. And within this, these regions, there is a center, or there is a hub which is responsible for the policies and the guidelines within this region. زي ما الدكتور طارق قال، احنا هنقعد مع بعض نطلع كل فاميلي داتا، لان في كلام ممكن من يو اس ومن يو كي ما يمشيش في مصر. That's fine. It's not going to be a problem so long as you're putting your own local policies and there is the basic that you're surrounding your activity around it. That's fine. I think we should not stop. ده رأيي أنا الشخصي even with the second wave. And I think زي ما هشام قال ان there will be more data. And I'm very interested in هشام يبعت لنا لو امكن طبعا provisional. Then this data about less than 1% in the elective activity with COVID negative patients, asymptomatic, less than 1% mortality. I think this is a very important data to come out and to be shared. And this will give us more encouragement.
Support. Dr. Ahmed Afifi, we're concluding the meeting, but then I noticed Dr. Haitham was mentioning in the US everything is maybe moving quicker and faster, but أكيد everything is evidence based. وأكيد we're shaking your head، فأنا كنت عايز أعرف في حاجة ورا الموضوع ده ولا؟
أمريكا السياسة بتتحرك كتير قوي فيها. I'm not sure إن النظام الصحي في أمريكا هو المثل اللي حد يحتذى بيه. كله في أمريكا هايل. نظام الامريكان بورد اوف بلاستيك سيرجري الافيدنس اللي احنا بنعمله في الطب از فانتاستيك، بس النظام الصحي في امريكا انا شخصيا شايف ان هو ده النظام الصح. ما اعرفش هشام رايه ايه، بس انا في عيوب كتير قوي فيه، السياسه هي الاساس فيه.
دكتور هشام؟
There's just a lot of politics in the US. So I agree with Dr. Ahmed إنه politics affects the things، بس at the end of the day don't underestimate the American system. وأحمد قال كده في المرة اللي فاتت إنه it will come up on top، لأنه at the end of the day the free people with free thinking and honest reporting will probably win. I will do my best to get the data يا هيثم. I'll send it to everyone once. I think this is preliminary data, but I'll try to get it even and send it to everyone. Thank you.
Thank you, Shema. Thank you very much. Now, what I was saying about the evidence, I was saying that the scientific evidence which will dictate the planning is there. يعني لما evidence بيقول ان انت you can resume activity while there's a second surge. Actually انتوا ما عندكمش لسه second surge، انتوا لسه في first surge وعندكم ارقام كبيره. And despite of this you are continuing. احنا definitely and categorically we wouldn't have started like you've started with these numbers. Definitely. احنا ولما الارقام بدات تنزل جامد جدا بدانا نفكر في قصدي احنا واخدينها انا much more I would say cautious approach rather than like yourself. And I think to be honest, and I have to admit this, I think it's proved to be correct because we are starting. Maybe we are cautious. I think this is good, but we are going back to, like for example, the 3 days. We are resuming the work. We are planning to go back to 80-90% within the next couple of months. But I'm not talking about the system itself. I'm talking about that the opening and the resuming of the work was evidence-based there. Not just opening like this and what happens. So I think we are concluding that we have to resume back the work. There should be no يعني في مصر المفروض ان احنا نبتدي نرجع نشتغل تاني بطريقه فمزي تحطوا local guidelines، تحطوا precautions كلها بحيث ان ما يبقاش في لاك داون. ان this will not end. And I think one of our very deep professors has mentioned that we have to live with the coronavirus. I agree totally with him. Even with the vaccine, I don't know if the vaccine is going to be quite effective or not, but I think we should resume back the work.
Thank you, Dr. Haitham. دكتور طارق، which approach حضرتك شايفه بنعمله في مصر؟ يعني في انجلترا يعني اداني ابروتش بهدوء being secure.
حافظ على الاجابه
انا قلت يعني اوكي
حافظ، لكن انا شخصيا عندي تصور معين وهعرضه المره الجايه في البرزنتيشن
ان شاء الله.
يعني هعرضه في اطار البريس ريكونستراكشن ولكن هو هي يعني ممكن ان احنا الكلام ده نطبقه على على كل السب سبيشاليتيز او كل البرانشز او يعني او التخصصات كلها يعني. فخلينا نشوف كده وربنا يسهل. الموضوع محتاج ديسكشنز كتيره يعني، ديسكشنز لوكال يعني. احنا متشكرين طبعا للتجربه اللي خدناها من ال NHS ومن اليو اس، واي هوب ان احنا ان شاء الله نطبق جزء كبير منها يعني باذن الله.
شكرا يا فندم. دكتور خالد انت عايز تختم حضرتك؟
يعني انا بختم القصه بتاعتنا باي ثانك تو everyone. وبس انا يعني شايف ان البروبلم في مصر، هو هيثم كان very precise في كلامه. احنا قريبين جدا للنظام الصحي البريطاني in Egypt، بس ما عندناش one body اسمه زي ال NHS كده هناك. احنا عندنا وزارة الصحة وعندنا الجامعات وعندنا different areas، فكله بيحط اللوكال جايد لاينز. وزي ما طارق قال دلوقتي I think ان كله هيتعايش وهيرجع. و I don't think even with an extensive second wave all over the world هيحصل لوك داون في الهيلث او الميديكال سيرفيس اللي موجوده. وده اللي ابتدى يرجع في القصر العيني وابتدى يرجع في وزاره الصحه. و I think الكلمه الجميله اللي قالها الدكتور ماجد المفتي وقالها جميع المشاركين، ان الكورونا فيروس هيفضل عايش معانا. احنا we have to work بالبوليسي دي and I think we can succeed. And thanks all. And waiting بقى next week لطارق الكلام الجميل اللي هيقوله على our benefits from these all experience. And thank you all.
شكرا دكتور خالد. و thank you everyone for attending, participating. أستاذ دكتور خالد، دكتور طارق، دكتور مأمون، دكتور هشام، دكتور أحمد عفيفي، دكتور هيثم، طبعا حفظ الألقاب. Thank you for everyone who giving us their input و showing us the magnitude فعلا المشكلة دي. وإن شاء الله soon we'll have our guidelines وإن شاء الله overcome المشاكل دي و restore everything back. إن شاء الله الحد الجاي هل announce الميتنج بكرة أو بعده إن شاء الله. و see you next Sunday إن شاء الله نفس الميعاد. شكرا. شكرا.
شكرا جزيلا. Thank you very much.